Good afternoon. I'm Dr. Chen here. Today, my telehealth will be on the two parts. First part is blood pressure recordings. It's for everyone who takes blood pressure. And the second part is on the clinical or for clinicians. The first part, I'd like to introduce you this study that was done by a pharmacist. They say that during the telehealth consult and the clinic care consult for hypertension, the outcome is the same. So the control for blood pressure is exactly the same. What I'm trying to do is to do a safety network for all of us who do blood pressure recordings. So the telehealth first part is for everyone who do a BP recordings. So as in all telehealth, there are steps to check and make sure that we are talking to the right person. There's name, address, date of birth. Get his consent, make sure there's no hearing or visual impairment, and is kind to ask whether he's got experience with technology and whether to check whether he's got any cognitive impairment or there's a third person in the listening room. Now, then we go to step 2 on BP measurements. So BP measurements it's appropriate that you take the blood pressure on a bare arm. So not one with a jumper, but on a bare arm. And don't be anxious, don't be angry, and you must sit up with back straight. And we check for bilateral arms so that make sure that we are not dealing with a subclavian steal syndrome, where there is a difference of the blood pressure between one arm and the other. The systolic pressure is different by 15 millimeters of mercury. Don't cross legs and don't chat, and don't drink coffee before your BP recordings. There's a thing called calf inflation hypertension, where your blood pressure can be manually, if you do a manual recording, you can inflate your pressure by 12 to 9 millimeters of mercury if you do it the wrong way. That is, either you inflate the blood pressure, the systolic blood pressure, less than 30 above systolic blood pressure, and also if you're dropping the beats at more than 1 to 2 millimeters mercury per beat. And there's always the tendency of white coat versus mass hypertension. Mass hypertension is when the blood pressure is abnormal at home but normal in the surgery. And white coat is exactly the opposite of mass hypertension. So this is a step 2 summary of all the things I've stated earlier, the ABC criteria. And step 3 is then you have to grade, because once you take a blood pressure recording, then you have to grade your BP recordings as whether it's normal or abnormal. So what's normal? So the normal follows the national and international definition of hypertension in 2017. So it's optimal, normal, and high normal. And you can see that the readings are as shown in the table here. What's abnormal? So most of my patients ask me what's abnormal. So when you have a blood pressure that is, say, the systolic is 160 and the diastolic is 90, you take the lower category as the final conclusion. So this is grade 1, grade 2, grade 3, and systolic hypertension is only the systolic blood pressure is elevated. Now, step 2, this is the part 2, the approach to control hypertension. Again, it has got the 3 steps. So it's got the initial one will be the history. So in history taking, we normally look for the cause of the blood pressure and look for red flags. And there is any red flags, we refer to emergency. So we write to the Socrates mnemonics as symptoms, as to see whether he has got any organs pathology, such as shortness of breath or proteins in the urine, and look for secondary causes of hypertension. And then as you go down, the onset, the causes, and resistant hypertension is defined as blood pressure recording above 140 by 90 with 3 antihypertensive medications, including a diuretic, and for 1 month, and you're not able to achieve the target of 140 by 90. And the alarms I will describe later on in a slide. Treatment, as you know, that it can be either induced or we want to know how they've managed their hypertension all this while, and whether their extracurricular activities are contributing to the elevated blood pressure. And they have to round up the history. We do a SNAPO, which is smoking and nutrition, alcohol, and all the comprehensive history and occupational history as well. So in alarms, in the history, in alarms, these are the alarms. So in accelerated hypertension and malignant hypertension are emergencies. L is loss of proteinuria, and acute drop in the eGFR within 3 months is also significant. And secondly, hypertension and subclavian, wherein symptomatic, is also significant. All right. So then if there's not an emergency, then we go on to do a step 2 and to find out why is the hypertension uncontrolled. And this hypertension is this sort of last mnemonics is used to in any chronic scenarios to find out why is a chronic disease not controlled, as in diabetes, as in asthma, as hypertension as well. So it's always the lifestyle is the reason to explain. Adherence is either they run out of money, or they're short of money, or they got side effects, or they got transport problems to get the medications. S is a systems recall. Systems recall means that it is a fault on the surgery or the clinic to inform the patient to come back for an appointment. And secondary hypertension is a common, and the common things in secondary hypertension are only 5. There's chronic kidney disease, renal artery stenosis, medication-induced obstructive, and cons. Rare are the thyroid and pheochromocytoma with Cushing's syndrome and coarctation. And substances that are induced hypertension can be either due to non-steroidal anti-inflammatory, estrogens, contraceptives, antidepressants such as Effexor, and a lot of C's like steroids, corticosteroids. And therapy inertia is when you're sitting in a big surgery and you find that the blood pressure is high, but it hasn't been, appropriate steps have not been taken by your colleagues. So when to screen for secondary hypertension is when the patient has resistant hypertension, recurrent pulmonary edema, emergency, and for new onset. And there are a few A's with age less than 30 years, young onset hypertension, acute kidney injury, and atrophy of the kidney, and incidentoma. And L is for loss of proteinuria, low potassium. But low potassium is only seen in 20% of Conn syndrome. So 80% of Conn syndrome have a normal potassium levels. And loud snoring is for exclude obstructive sleep apnea. And then we go to the last step, which is examination. So in examination, we look at the weight and the eyes and oral cavity and the neck, the skin, and we look at also the extremities as well. Look at the digits. As in subclavian steel, we have to look for whether the patient has got any ulceration or splinter hemorrhages or some sort of skin changes such as libido reticularis. The other findings we can check using case studies, which I'll describe later on. We also look at pulse pressure. We look at pulse pressure where there's a difference between the systolic and the diastolic blood pressure. So there are either 2 abnormal pulse pressure. One is less than 20, which is a narrow pulse pressure, and this can be seen in heart failure, in aortic stenosis, and also mitral stenosis as well, and also hypertrophic cardiomyopathy. While pulse pressure is due to old age and is also due in septic shock, and we check for both blood pressure at least once, so that and the pressure, if it's more than 15 to 20 millimeters mercury, we have to exclude subclavian Steel syndrome. So I gave you 3 case studies here as a part of examination. So Ahmad has been 45 years of age, had coronary bypass surgery a month ago, and non-ST elevation myocardial infarct. So it's progressing well. It has a telehealth appointment. His blood pressure was high. So he's a young blood pressure patient, had coronary bypass surgery. And so what sort of surgery? So when you talk to him, we want to rule out that whether he has any familial hyperlipidemia. And this one, because it's a very young heart attack before 55 years of age. So the further history is they probably need to check for is whether his family has also a history of young cardiovascular issues as well. And so based on point system, we determine whether Ahmad has got definite or probable familial history. So he's got 2 points definitely because he's 45, and this scores 2 points if the patient has a premature coronary artery disease less than 55 years of age. So we ask for family history in Ahmad's case. Zentil asthma is you can see plaques appearing. This is common. It doesn't indicate any sort of familial hyperlipidemia, but it's associated with elevated total cholesterol and also seen in patients with has got elevated LDL as well. So we look for, these are eruptive xanthomas, and this is also not cutaneous. These are cutaneous xanthomas, but they don't score any points in familial hyperlipidemia. Tendinous xanthomas are only seen in 20% of familial hyperlipidemia, and they score 6 points. Arcus senilis is the grayish ring around the eye, and is seen in only 20% of familial hyperlipidemia. And this is what scores 6 points, so that's tendon xanthomas. So these are the summary of the cutaneous xanthomas that I've drawn out. But only the tuberous xanthomas, tendinous, will show up in scoring of the points for familial hyperlipidemia. Familial hyperlipidemia is seen in about 50, is seen out of 500 individuals, 1 out of every 500. This algorithm release is seen in used in Australia to determine who are the patients who shall be referred to a specialist. Second case is Nancy. He's got a weight gain of 9 kilos over the last 3 months. So he's got moderate hypertension, so again uncontrolled high blood pressure, and she was prescribed prednisone over the last 3 months. But she was defaulted treatment because of the COVID, and she has been on steroids for a long time. She actually developed Cushing's, drug-induced Cushing's. Again, with telehealth, we can pick up Cushing's syndrome. And we're looking at the throat, we can rule out whether she's got obstructive sleep apnea as well. In case 3 is a city, has got 38 years, and she's got weight loss and fatigue and palpitations, and the blood pressure is also high. She's got a unilateral exophthalmos. By telehealth, we can actually pick up that there's usually in Graves' disease, there's a bilateral. In this case, there's only a unilateral exophthalmos, which is a diagnostic challenging area. And look at the neck, is smooth and diffusely enlarged thyroid gland. This is not seen commonly, but seen only up to 1 to 2%. This is pretibial myxedema. Commonly will be the eye signs, which is seen up to 50%, and the goiter. And that's nodular goiter, which normally can also be a multinodular goiter, can also be seen in Graves' disease. However, in Graves' disease, it's only the thyroxine is converted to T3. So there are a few conditions that in thyroid cases where the enzyme does not convert T4 to T3. Example will be the thyrotoxicosis in elderly patients and amiodarone-induced thyrotoxicosis, where you don't get cardiac issues with thyrotoxicosis. So in elderly people with thyrotoxicosis, you get myopathy, you get weight loss, but you don't get cardiac issues. And this is the end of my talk today. So I gave you 3 case studies. So a few inspection signs can be picked up. Unfortunately, we can't do palpation and we can't do auscultation. And so these are a few examples of what there are limitations to an examination with telehealth with hypertension. And hope these slides will be of help to you. Thank you.